Um,
There we go.
we are going to record today because a few people have been unable to attend and are interested in hearing from our guests. And that's also why we had to switch to Teams or to Zoom because we all have trouble sharing recordings outside of Teams. So thanks for your patience with that. And now I will turn it over to Jeremy.
Thank you, Molly. Well, probably don't need to do much of an introduction for Delegate Rasoul, but we're thankful for having him join us in today's community health conversation. Delegate Rasoul has been a member of the House of Delegates since 2014. It represents the 38th district here in Roanoke, chair of the Education Committee, amongst many accomplishments. And I'm sure a lot of us had a chance to work with him the last couple of years, particularly on the Catawba Hospital investments. So I know he's very involved in this community, and we're excited to have him join us today. And we asked him as we get ready for the General Assembly section to maybe share some thoughts about what we might expect as folks in the community health space, and then provide time for some Q&A. And also, as long as he has the time to hang around, we will do our usual info share at the end of this meeting and be an additional chance for Delegate Rasoul to hear some of the issues in our nonprofit and health community here in the Roanoke Valley. So with that, I'll turn it over to Delegate Rasoul. Thank you for joining us.
Yes, good morning. Thank you to Healthy Roanoke Valleys. Thank you to Jeremy for inviting me to be with you this morning. I'd love to keep this as much of a conversation as possible, but I'll give you just a few highlights as to what we are anticipating going into this session, and then also given the governor's budget unveiling, which happened on Wednesday. Typically, the governor unveils the budget this time of year, and it's several weeks in advance of the General Assembly session. As many of you know, the budget for this governor is a preface, but with a new governor coming in, it's a bit of a lame duck. But however, there are some components that we will have to address regardless of who the governor is. And so certainly we'll think through some of that. I think most folks are on the same page, and I'll do my best to keep as many of these comments as apolitical as possible, but there's a lot going on. So really currently we have the effects of HR 1, the big bill that passed this summer, and the standoff or shutdown that occurred was for a couple of major reasons. One was, of course, all of the cuts to Medicaid that are being proposed. And then second, the cuts to the healthcare subsidies. So, as you know, what we have what we've traditionally had is healthcare.gov. We've had this federal marketplace. And the federal marketplace has allowed for people to be able to buy health insurance with federal subsidies to bring down their premiums. The state recently, in the past couple of years, has taken on that role and created its own marketplace. And so without the renewal of those subsidies, then we'll see premiums jump for many families by 3 and 4 times because they will just have to pay whatever the market rates are then at that point. So the shutdown occurred. There wasn't a reconciliation around either one of those points, major points. However, there was the promise to continue conversing around the marketplace subsidies. And the most recent news is this week is that there are some Republicans in the U.S. House who are breaking with the Speaker to potentially force a vote on the subsidies. And there may be an appetite in the Senate, even though the Senate was unable to pass a piece of legislation, the U.S. Senate able to pass a piece of legislation to authorize it. However, there are a number of Republican U.S. senators who want to partner with the Democrats to find some kind of solution. And I think that a whole host of folks on both sides of the aisle realize that this is a critical issue for a lot of working and middle class Virginians and Americans. However, that completely ignores all of the changes that the big bad bill made to in HR 1 to Medicaid itself and some of the expansion population. So here in Virginia, we're in danger of losing around 300 upwards of 350,000 people off of our Medicaid rolls. And over 50,000 of those are in rural areas and many of those areas in which you serve. So we're trying to, number one, see what might happen at the 11th hour in U.S. Congress to extend these subsidies. Should the state take on that full burden of paying for those subsidies, it would probably be about a quarter of $1 billion for Virginia to pay for that, or at least for most of it. That was not included in the governor's budget. What the governor did include in his budget is there are cuts and modifications to SNAP programs. And what he is stating is that, roughly $100 million would go towards not necessarily direct benefits for those impacted by SNAP, but for the shortfall that the state is going to incur from the federal government. So the federal government has said we're going to have penalties for states that don't meet certain performance measures. And because of those penalties, which we can talk about separately, he has budgeted some dollars to be able to cover that, as opposed to cutting people back from some of the SNAP benefits. So here's where we're at, big picture, going into the budget as a whole. Currently, Virginia is slightly ahead of revenue projections, so meaning we have a bit of a surplus that's occurring. However, Virginia is maybe second or third as far as states impacted by cuts to the federal government. And what we found is, based on the latest numbers, that in October there were 100,000 job losses based on the cuts to the federal government. So that is now starting to impact some of the revenues that are coming in. And so there are kind of three big things. We'll have a little bit of a surplus. We have a large Medicaid, separate from what's happening at the federal level, a large kind of Medicaid rebenchmarking, where we have an increase or changes to Medicaid, increases in rates. That will be about $2 billion. And then we have what's called rebenchmarking for schools. So it's level setting. All right, what are we doing for the new biennium for schools, given the new attendance and some of the other things that we have said we're going to be funding moving forward. So that's upwards of $1 billion in just the education rebenchmarking. I mentioned healthcare and education because from a state perspective, those are our two biggest buckets of funding. And so we think of the state budget as far as general funds and non-general funds. General funds are monies that we raise in Virginia and then we spend it in Virginia. Non-general funds are federal dollars largely that come down and then we distribute. And so from a general fund perspective, education and healthcare by far are our two big buckets. And those are going to account for just several $billion in expenses that we will have regardless of what else we want to do. So we'll have some decisions that we're going to need to make as we move forward. We have yet, many of you know that the federal fiscal year began October 1. And with its beginning in October 1, that's why we had such a large amount of job losses registered to October. We don't have the full November numbers yet, and then going into December. So the economic impacts to Virginia as a whole is still a big question mark. Um, like, you know, we're the Roanoke Valley and Southwest Virginia. We've had several hundred plus job losses here, just from the impacts of the federal government. However, of course, most of it has been in Northern Virginia. Why do we care about Northern Virginia? And the reality is that that's a decent tax base for the Commonwealth of Virginia, and so that will certainly be driving what happens for us. Now, it's not only those who are directly employed by the federal government being laid off, but we also, because of our large military and contractor base, I think we're the second largest in the country. A lot of those contracts have been impacted. And so that's essentially doubled the impact for Virginia in the number of job losses and what has happened. We have since heard of a number of medical closures here around rural Virginia, a few just to the north of us. And with a couple of pieces that directly impact our hospitals, they're trying to determine, um, if the federal government will make any modifications last second potentially there as well. Two large modifications to the way we reimburse our hospitals and look at our hospitals are certainly under threat right now. Virginia will not, be able to fill that hole, and so we will disproportionately, I think, feel that impact. And while we are grateful and have the Carillion Network and even the HCA Lewis Gale Network, the reality is that something's probably got to give at one point or another. So we'll be keeping an eye on all of that as we move forward. I will say you've heard some folks say that there are dollars in HR1 that were specifically for rural healthcare. That's really kind of pennies on the dollar, and so I think keeping all of that in mind is important. That it does not make up for the losses that these healthcare systems, especially these rural healthcare systems, while they did earmark some money, it certainly won't make up for that. I see your message in the chat that you'd like. I'm not bringing great news on this Friday, especially the Friday before Christmas week. So let me try to give, I guess, a little bit of. I'll try to find some of the bright spots, so you guys aren't hating on me all Friday morning as we go into the weekend. At this juncture, I mean, the economic outlook is not as bad as we anticipated based on the numbers at this point for Virginia as a Commonwealth. And so the latest projections do not show Virginia itself. We were worried a few months ago that we would be inevitably in a recession. But the projection is that we're clearly going to have a dip, but it may not reach recessionary levels at this point. And so that's a bit of good news. And I was pleasantly surprised that in our appropriations retreat and in our meetings, which are of course all public, they did say that we are still currently running a surplus. So our revenue projections were like 3% year over year as far as growth, and that's been closer to 5%. We tend to budget pretty conservatively regardless in Virginia. So things, revenues, which means cash coming in, because Virginia is on a cash basis, are not quite as bad as we anticipated. So good news. Plus, we have a $4.5 to almost $5 billion savings account. And that savings account really is good for like one-time issues. So if we ever like run into an emergency, Virginia has the ability to be able to plug some of those holes, not holes in perpetuity, but we certainly have that. And in the proposed budget, while we'd like to be able to do more, the governor's proposed budget did have a 2% pay increase. We're hoping we'll be able to bump that so it'll at least keep up with inflation. So generally speaking, we're trying to figure out, what all this will mean for us in moving forward. Now, that's the largest kind of piece of this, maybe the most boring as far as the numbers are concerned. I will say, before we just open up to any questions that you have, it's impossible, I think, to ignore from a public health perspective, kind of the impacts of all of the other components, meaning, ICE on our streets, families who are afraid to come and receive public service benefits because they feel intimidated by the system as a whole. We see that there are a number of needs here locally. I think you might have seen the piece that showed that we've got a wait list of 4,000 people for Section 9 housing here in Roanoke. And so as we know, as being the largest city in the western half of the state and being really a place where people come from hours away to receive the help and support that they need, we're certainly a kind of an integral player in all of it. So we're keeping all that top of mind. So with that, let me pause and open it up to some questions, and I'll let you, Danny, ask me, or others ask me leading questions so I can give more positive updates about some other things, because there are some good things happening. It's just a matter of unpacking them together.
Um, Before we move on to the positive, and thank you for letting me tease you a little bit this morning. My question actually, I remember at the very end of last legislative session, they had the legislators kind of noticed that we were dangerously close to this trigger law for Medicaid expansion. In terms of I think it's like a certain percentage of the budget. I can't remember quite the details, but basically, I remember a bunch of legislators coming together being like, we need to pass the legislation really quickly to make it that we don't take away our Medicaid expansion if we hit a certain spending category, I think it was. So I just wanted like an update on not so much the federal impact, but what's going on with this year's Medicaid funding 2026, and making sure that legislatively we're set up well to protect Medicaid as much as possible in before 27.
Yeah. Well, you didn't do a good job of asking me a leading positive question, Danny, but
Sorry.
it's okay. It's all right. Here's the reality is that look, we're going to put a couple $1 billion extra into Medicaid, and however, it's not going to plug the federal holes completely.
Right.
And we'll be able to do some, but it's just too big. What we were discussing was in anticipation of HR 1. What we were discussing last session was in anticipation of HR 1. HR 1 passed pretty much as bad as we could have anticipated. I think that there was a little bit of buyer's remorse from some of the U.S. senators who voted for it. And as they went back to their districts in August and realized, oh, I have poor areas, I have poor states who actually really benefit off of some of this, and we need to do something about it. And I think a lot of them would actually like to see something happen here. It's just people having the political fortitude to do that. So bottom line is that we won't be able to plug those holes for maybe a couple few 100,000 Virginians. And on top of that, we're going to have to spend a lot more money just to comply with some of the new Medicaid regulations. For example, people are going to need to be reassessed every 6 months as opposed to every year to see if they qualify for Medicaid. That's going to take a whole tens of millions of dollars in a technology upgrade, in addition to the man hours that goes into that. Amongst some of the other things like some additional work requirements and whatnot. And just so we're on the same page, the reason why we're against, somebody like me is against work requirements from a Medicaid perspective is because when you're qualifying for Medicaid, you're qualifying for the family. So let's say that I have a parent who, doesn't meet certain requirements as from a work requirement perspective. You're potentially punishing other parts of the family because of that, and certainly making things more difficult there. So we're going to do the best that we can at our level. Fortunately, I think you're going to have everyone focused on it, the House, the Senate, and the governor, which will be welcome because everybody's going to be asking the question, how do we help, as opposed to should we help?
Great, thanks.
Thank you.
Mary Beth, I see you put a question in the chat. Do you just want to go ahead and unmute and ask? Here.
Sorry, I'm babysitting some loud dogs this morning. So, yes, I work quite a bit with healthcare agencies across the state, particularly the community service boards, and have repeatedly heard over the past 5 to 10 years that TMAS as an agency is really broken and is not working as it should to be able to manage contracts, as they've moved to the managed care system, and also to be able to better assess the actual cost of delivering healthcare services across systems. So I know there's some efforts, some discussion about completely reorganizing, restructuring DMAS, and wondered if you would be in favor of that move.
The way most of, thank you for that question, Mary Beth. The way that most of Medicaid is administered today isn't per se through the state government. Most of Medicaid is administered today largely through third-party providers, through other insurance companies or MCO, managed care organizations. And so that you either have, we're split up into regions across the state, and various providers, MCOs, bid on trying to manage the population within that region, that Medicaid region. Separately, we also, so you kind of got, you have those who are impoverished, coverage of, in a second bucket, coverage of children, and then a large bucket is also, from a cost perspective, is also the aged and disabled, so nursing home care, et cetera. And so most of the people who are covered are through these managed care organizations. And to be as objective as possible, the thought is that a managed care organization maybe sometimes gives you a capitated model that helps to control costs. So you say, hey, managed care company, here's this money, manage this population. And so they have an incentive to try to do as much as they can to manage the costs associated with that population. The downside is that that's where the incentives are. It's like pushing down costs. So that may impact services. That certainly has them sometimes making difficult decisions. And for a lot of folks, because there's that profit premium for many MCOs, not all, but for many MCOs, that's kind of viewed as maybe some money that's not well spent in the whole calculation. And so we continue to kind of think through what's the best way to do things here. I will tell you, there's a whole lot more we should be expecting of our MCOs or managed care organizations. in the services that they provide and the work that they do in helping manage some of the populations. There's certainly obviously a lot of reforms that need to come to Medicaid as well, as far as becoming more and more efficient. However, under Republicans and Democrats, the director who's been there for several years, Cheryl Roberts, I will say that I believe that they've been making more and more progress at becoming a tightly run organization. But there's still a long way to go because a lot of these services are just underfunded and providers are very frustrated.
Thank you. I don't see any raised hands. I'm going to jump in with a question on behalf of HRV and let some other folks have a chance to mull. But I think one of the things that this group has been interested in Sam, is advocacy. You know, there's a lot of issues locally. A lot of the stuff you described certainly has downstream effects for everyone in this virtual room who's doing work in this space. So what are some things that we can be thinking about, or we could do either as HRV as a collective, or some of these individual folks, to help you or to get information up to the General Assembly in the coming session, or just some advice you might have for how we can elevate some of the needs in Roanoke Valley up to Richmond?
Yeah, look, I know a lot of the folks on this call they have a heart for public health in lots of different ways, whether you're a social worker, a primary care provider. I tell people all the time, it is just impossible to divorce the care that you offer day to day with the advocacy that you need to do. And so I would just come up with a firm rule that 10% of your time has to be in advocacy. And we're not talking about lobbying. Like your nonprofit, all of this, we hear people, oh, we're a nonprofit organization, but that's a bunch of baloney. You can be strong advocates, and you, in fact, really need to be. And if you think things are tough now, we have several years left of things, austerity measures and other policies that are going to be implemented on a monthly basis that are going to make all of our lives more difficult. So I think it is critical that all of us have an intentional advocacy plan, certainly at the state level, but beyond that, and figure out what we should be doing in meeting with our legislators, certainly voicing your opinion. And the people who are on this call likely are, I would not consider this to be an average group of citizen advocates. And so, simply signing on now, if you don't mind me, Jeremy, I'm just being forward, signing a petition or something like that. I mean, that's almost a waste of time. What this group needs to do is to think through what are the pieces that we're going to do. When is the next meeting that we have set up with our federal representative? When are we scheduled to go down to the General Assembly and meet with our local delegation as well as others to speak about specific topics that impact our work and our community? How are we activating? This is an important point. How are we activating our boards? Because our boards largely are filled with connected and affluent people, and all of them need to embrace the idea of advocacy. And so everybody on this call should be thinking, oh, I have a relatively powerful board in one way or another. How can I activate them to be better advocates and coming up with a group plan to help in moving forward? Over the next several months, you may be more or less effective. But if you think it's going to stop with HR1, we're wrong, right? There's going to be more to come. So, thinking through that advocacy engine. And again, you have the charge to be strong advocates and educate as much as possible, and that is not in conflict with your charters as largely as nonprofits. And I would encourage you to take advantage of that and to make that an intentional part of every one of your board meetings, of your your higher end executive retreats, and certainly in these spaces.
Thanks, Sam. There is Aaron's got his hand raised, and then I saw Danny has a question in the chat. So we'll do Aaron and then Danny.
Thanks. Sam, I just want you to be aware of a committee that we have. So the Health District and Dr. Morrow coordinate our Healthcare Safety Net Committee that has Carilion, Bradley, New Horizons, and Fralin. And we meet monthly and are really thinking about, how as a safety net we can coordinate and better serve our patients, and especially increase acute care and, really easy coordinated access points. So we're actively thinking about how we could do that and really coordinate better to be more efficient, to see more patients. And I think one of the things that we're really thinking about is how do we build APP, like nurse practitioner capacity, and how can we coordinate a system of care for our underserved and not have to worry so much about Stark laws and anti-kickback laws, but really truly as a safety net model of care. And then also increase supports like community health workers that help get people connected to community resources. So that's where we've had a lot of discussion, and we would welcome you to come to any of those meetings or any ideas that you have. We've also talked about how, as safety nets, free clinics, FQHCs, not-for-profit hospitals, we can better advocate together. So would love to have some more conversations about that with the group.
Yeah, thank you for that, Aaron, and thanks for your good work. Happy to join you all and talk about advocacy efforts and to think about how to build some of these structures. Look, in highly impoverished areas, I tell, I used to do some NGO work in primary health care, maternal child health, and emergency nutrition in East Africa. And I remember having to pay people to help them. So, you'd have these pregnant and nursing mothers, and you'd want them to come to some kind of training or some support. And we would have to pay them to come and to do that. The reason is because when you don't know what you don't know, then you're not seeking out the answers to what you don't know, right? So, in specifically in some of our communities where we have high rates of poverty, and nearly all of our schools are Title I schools. We have a very high Medicaid utilization rate relative to all of the other districts in Virginia. Then, to me, healthcare needs to continue to evolve to a model which may be employing more community health workers. But the point is that that there's a case management function where that you've got community health workers. Let's go with that term for now. You've got a community health worker who has a portfolio of families, and their job is to just be a single point of entry for those families and help navigate them to resources. Because right now, our systems are created where there is some help, there is some support, not enough, but that they've got to navigate through that, which is terribly difficult. And even for folks who are, well educated and even well resourced, sometimes it's difficult to navigate a lot of these issues. So I think continuing to do some of your good work and invest in that kind of hub and spoke model. And so you may have heard me tell the story about when airlines first started, they tried to book flights from one city to another and try to fill all of these flights. And they realized quickly that doesn't work. You have to fly everyone into a hub, and then they fly out to other cities. And so I think continuing to think about if we're going to help these families, if we're going to dig down deep into the most impoverished areas that are in need, how do you create that kind of referral system with the community health workers that then can feed into your nurse practitioners, your APP, et cetera? And that is the way, because in theory, we think that it's cheaper for preventative health care or early onset primary health care than to wait for an acute episode. And if that is truly the case, which I believe it is, with all the numbers, of course, tell us that, then we've got to kind of dig down deep into this hub and spoke model throughout the community.
Sam, I really appreciate that. And I think one of the things that we've been working on as HRV and as a community for a long time is really systems thinking around community health workers, better, social navigation, knowing health-related social need. If you're not getting your basic needs met, you're not going to prioritize healthcare need. And a couple of things that we've been able to accomplish is we now have screenings in the ED and in our hospitals for social determinants of health. And my team is able to work with our social workers to get referrals from the hospital, from the ED, but then also community providers. But what we're working on is like, how do we do better proactive outreach, but then also coordinate community health workers and peers to help with not only that resource coordination, but the health behavior change and trust building to get the right care at the right time. And really like a no wrong point entry into this type of system. And I think there are opportunities to see how like our community safety nets we can all operate on a single system like RedCap or Carillion's EMR, because our team does have our own EMR with CHWs documenting in the system now, which really brings us into part of that broader care team.
Yeah, and the reason why I was and I think we're continuing to head in a more positive direction. The reason why I was hesitant to use community health workers is because sometimes when we say community health worker, it is siloed in health, and really what you want is, for example, when I first got elected, I didn't tell people I'm a delegate. Here's what I do. Contact me for these types of services. People don't understand. They call me congressman. They call me city councilor. They don't know the difference. And I don't want to explain it to them. I just give them a card and say, call me when you need help. So that way they know, hey, call Sam, call this person, community health worker, when I need any help. Like I need to figure out how to get to the employment benefits that I need. I need to figure out how to get some nutrition. I need to figure out where can I go to get some dental care, et cetera. So, and I think a lot of what you all are doing is that. I think that you're having more holistic conversations and engagement. But I need the problem solver in my life. So who's the one person I can call and can say, man, and of course they're not going to have all the answers, but part of their job is to know who to call to get the answer. So they can say, I'll call you back in the afternoon. Let me figure it out. So the more and more that we can collaborate in that direction, I think the better off we'll be. So great work.
Danny, if you want to ask the last question, I want us to have time to do our usual info share, and then we've got a update from United Way we want to make sure we get in here. So we'll get one more question in and invite the delegate to hang around for the rest of the last 15 minutes or so of the meeting.
Yeah, thanks for letting me ask a second question. One of the things that I'm really concerned about for calendar year 27 is if we aren't able to address the Medicaid cuts at the federal level. A lot of people are here in Virginia going to face those work requirements and volunteer requirements that if you're having substance use disorder and on methadone and Suboxone, for a lot of those people, it's like they have started their path to stabilization. They are not capable of working yet or volunteering. And my nightmare scenario is hundreds of thousands of Virginians losing access to their methadone overnight because they are not able to provide the work requirements to keep their Medicaid. And so one of the things that I've been curious about is can we advocate with DMAS? Is there something that the legislature can do to add people with substance use disorder to special populations, the way that people living with HIV? Right now, it's set that they have to have disability. We all know how hard it is to get on disability, and I mean, I think I'm just sounding the alarm right now, of what it will do to fatalities, overdoses. Like we will have a mass death event if everybody loses access to their methadone or Suboxone overnight.
Yeah, so number one, clearly, if the state wanted to and could afford to do it, it could technically do it. Number two, I wish we had a different Secretary of Health at the federal level many times, and that would be helpful in having more objective conversations about some of this. But something to look into, which I hadn't thought of until you mentioned it, is as you know, we applied to the federal government for waiver programs, and I don't know if there are waiver programs in this space that then further allow us to technically recover some of that cost from the federal government that we could continue to expand upon as we move forward. And then third, this is an advocacy point, and sorry to mesh it all together, but there's a good, let's call it an advocacy book, but it's not one. It's called The Righteous Mind, and it's by Jonathan Haidt, and it talks about morality and the 6 facets of morality. So there's like 6 parts to morality. And when we're thinking about what's moral, we calculate them, but we weight them differently. And so the work requirement appeal. So you all are in you all weight very heavily something called the Care Harm Foundation. It's one of the pieces of morality. Like what's moral and immoral has to do with people getting the care or being harmed. And that's what you decide is what's moral and immoral. However, one other one is what's called fairness. And so what's used in the framing in your advocacy is it's not fair that these people aren't working and they're receiving these benefits, right? So you have to reframe that and think about what the fairness narrative is, or how to engage with that narrative, to talking about whatever else it may be, the impact to society. There are children that are involved, there are other family members, etc. And so just think about that from a framing perspective. So gave you a few things to chew on there, but we certainly could be exploring that as we go into 27.
Thanks. And what was the name of that book again? I read it.
The Righteous Mind by
Thanks.
Jonathan Haidt. Oh, it's right here. Right here. All right. I don't know if you guys can see that. Yes, you can. Why Good People Are Divided by Religion and Politics. So it's not really a community health book, but and it's a little bit wonky, but it actually helps me in my framing, because then I can't just be a bleeding heart liberal, because that's really what I am. But I have to communicate about what's fair. I have to communicate about, kind of liberty and oppression, following rules, things like that. Those are things that people care about. And so communicating all that together helps us be better advocates. So thank you so much, Jeremy. I know I've taken a lot of your time, lots of great questions. Feel free, of course, to reach out to me. Sorry if I was a little bit wonky this morning. There's a lot going on, but consider us an ally if we can ever be of any help. Continue working hard for the community. And as we prepare going into the General Assembly session, just know, as you can probably tell, I'm ready to fight tooth and nail for this community, for people who are in need. This is not a time to sit on the sidelines, and look forward to working with all of you to get good things done.
Thank you, Sam. Thank you very much for joining us. And it's not always pleasant, but it's good to know what we're up against and how we kind of need to band together and get this good work done. So I think, Molly, the next phase is the info share, correct? Is that we're moving into?
It is, unless you would like to go ahead and toss it to United Way briefly before we info share.
Yeah, so I think it's starting to start that. I've been involved in the United Way's public policy committee, and there's been a lot of good work happening there. And so I see Leslie, so I think I'm going to throw it to Leslie to talk about some of what's happened there. And this, I think, is a good segue from everything Sam was just saying about advocacy and so forth. So Leslie, go ahead and take it away.
Yeah, when Sam was talking about you must educate your boards and activate them to be advocates, and that's exactly what Abby is doing through the Public Policy Committee, which includes board members and community leaders. Um, Through that Public Policy Committee, there's been a framework recently established that gives some guidance to United Way about the topics, the issues they will be involved with, and the role that they will play. And that document is not, I'm not free to share the document itself yet, but what I can share are our priority policy areas. And you'll notice as I read them, and I'll just take a minute, that they very closely align with HRV and with the issues that many of our partners are dealing with in the community. So our priority policy areas are early childhood education and childcare, including out of time access programs, out of school time that support working families. We want to support competitive compensation and workforce supports for early educators. Facilitate cross-sectional regional roundtables with providers, schools, employers, create our United Way Ready Regions West infrastructure. Also, healthcare access and community health workers. We want to improve access to preventative care, behavioral mental health supports, and resource navigation through a strong and well-integrated community health worker workforce. And to do that, we really want to support coverage stability, healthcare coverage stability, and continued access to affordable healthcare. We want to promote consistent CHW workforce funding and integration into care models. We want to support advancing behavioral health access and alignment across sectors. We want to elevate CHW stories, local data, and barriers affecting care access. Continuity of essential supports during federal funding transition. So we want to ensure families and service providers remain stable during periods of federal funding changes, which, as Sam alluded to, we're not finished. There's going to be several more years of this. So things that affect nutrition, housing, childcare, workforce programs. So we'll be monitoring that through that public policy group, monitoring federal funding changes and adjusting our activities as that relates. We also want to provide civic infrastructure and nonprofit capacity. So we want to help strengthen those systems that make community stability possible, including 211 Virginia, nonprofit capacity, and the charitable sector collaboration. Things like supporting ongoing investments in 211 systems and nonprofits, aligning with statewide coalitions focused on nonprofit resilience, sharing ALICE, 211, and CHW insights to strengthen a coordinated response in our region. And then our other priority areas, workforce development and economic mobility. So things that limit employment, including childcare, transportation, housing, supporting job training, apprenticeships, workforce development programs, the greater workforce development boards, our chambers of commerce, and elevating the ALICE reality. So Sam talked about, as part of advocacy, really educating folks. Our ALICE population is struggling, folks. Those working families who just can't make ends meet are struggling desperately right now. In addition to all of the folks living under the poverty level. And then another priority area is our housing access and pathways to stability. So strengthening access to safe, stable housing. Sam alluded to the shortage in the wait list in Section 9 housing, and supporting prevention strategies that reduce displacement and homelessness. We know that that's a comprehensive issue. Um, that might include things like federal housing resources, Department of Housing and Urban Development, HUD housing initiatives, aligning with the Virginia Housing Development Authority and regional continuums of care. And again, sharing those Alice 211 and CHW trends. Lastly is food security and nutrition access is very important to United Way. Ensuring consistent access to nutritious food, especially in rural and underserved areas, supporting family stability and child development. Things like promoting continued investment in essential nutrition programs, collaborating with Feeding Southwest Virginia, LEAP, our regional food networks, using 211 Virginia and CHW Insights to increase awareness of available resources. Again, our CHWs are our rock stars in terms of being able to connect folks to resources in the community. So, one thing to know is United Way Virginia. So, United Way has a Virginia state legislative association with a public policy agenda that sounds very much like with the similar priorities to what I've just talked about. And our role at United Way is to align and support. So our plan is to align and support with any initiatives, lending our voice and potentially the United Way Virginia voice to issues in your organizations. So however HRV or partner organizations will choose to advocate, please let United Way know. HRV is a large voice. United Way Virginia is a large voice as well. United Way Worldwide is a large voice. So let's do this together. As Sam said, we really need to be collaborating. So just let us know. I've talked about our priorities. If your priorities align with ours, let's talk because we need to do this as a region, not just individual organizations. So that's my information share. Did I cover it, Jeremy?
I think so. Now there's a document, a more public facing version of some of the stuff that's in development or that will come out. Okay.
This document is our internal document that talks about the roles we will take in each of these areas. So it's very specific for our public policy committee, but those priorities are all the same, and you'll see that if it's not on our website, it will be out publicly very soon, that framework.
Well, and whenever that's ready, we can send that around, and then folks on
Absolutely.
the call, if your interests align with those, please, talk to United Way or talk to HRV leadership, and we'll help facilitate however we need to actions on those areas. So thank you, Leslie, and thank you for all the work for the Public Policy Committee.
All right, thank you guys. I know we are close on time, but we do still want to save a minute for partner updates and connections. If anyone has anything, you can either raise your hand and speak up or drop something in the chat. If you want to share any updates about your organization or any needs or challenges that you're facing, again, just feel free to share those with the group as we go into the last couple of minutes here. And Kim, I see your hand up.
Morning, everybody. I'll introduce myself. I'm Kim Jernette, and I'm the team lead at Urban Baby Beginnings here in Roanoke's fairly new maternal health hub. So if you're talking about resources for pregnant moms who are on Medicaid and helping to facilitate healthy pregnancies, healthy babies, healthy families, and offer resources, then this health hub here is going to be an advocate for those families. And we are so excited to be here and be an outreach for the community. We are going to start in January diaper duty once a month on Wednesdays, and I can send out more information about that so moms can come to the hub and get diapers. We offer formula as well, and anything else that they may need. And if we don't have the resources here, we can find them. And if you would like to participate in that, you can let us know. And if you have any referrals for us, we would be happy to help any moms in need. Thank you.
Thank you so much. And if you have information that you'd like, Emma can include it in our notes. Emma, if you want to drop your email in the chat, that would be great if for anyone who may not have it. Yeah, Ahu.
Good morning, everyone. Some of you may have received this information from me in an email, but I'm really relying on our community to spread the word. We are registering for the new semester of our programs, including 5 levels of in-person and online ESOL classes for adults, citizenship preparation programs, and English and digital literacy. One thing we've seen all across 2025 is steady restrictions of legal immigration benefits for our immigrant and refugee population. It is excluding them from multiple important sectors, including the health sector, the education sector, and the workforce sector, and English proficiency is becoming more and more vital. So we have reached all our learners, but we want to make sure those who don't know about our services know that they can come. We don't ask for much information when registering, and we are extremely affordable. So please help us spread the news, and I will share the flyers with Jeremy as well. Thank you.
Thank you so much. And Josh, if you'd like to jump in.
Hey there, and I guess so. Most of you can see my information, but I'm Josh Wright from Anthem Health Keepers Plus, and that's Anthem's Medicaid health insurance for eligible Virginians. But today begins Medicaid open enrollment for the Roanoke area and actually all of Southwest Virginia. And that's an opportunity for individuals with Medicaid to switch their health plan should they want to, or should their doctor no longer be a network, or maybe some medications that they need are not covered by their current MCO. But that open enrollment period will go from today until February the 28th. And should someone want to switch, they can do so by going on to the Virginia Managed Care app. If they have that, they can download the app. It's a very quick process. Or they can simply go to or call the Virginia Managed Care helpline to switch their health insurance, and I will put that number in the chat.
Awesome. Thank you so much, Josh. All right. I don't think I see any other hands up, and I know we are 2 minutes over. So we can go ahead and wrap up. If you do have something else that you'd like to share with the group, Emma Duff has put her information in the chat, so you can email that to her and she will include it in the minutes. So please, if there's something we didn't get to today, please email Emma or any one of us on the leadership team. Our next meeting is going to be January 16th, and it'll be 9 a.m. again, and we should be back on Microsoft Teams at that point. But thank you so much for joining us today. We really appreciate having you here, and appreciate all the work that each of our organizations is doing across the area. And we appreciate Delegate Rasoul joining today too, to share important information with this team. So thank you all. I hope everyone has happy holidays and maybe enjoys some slow time over the next couple weeks.
Thank you.
Thank you.